Dr. Lisa Fitzpatrick is a consultant that we recruited to help to put together this wonderful event. And I'm actually going to let her introduce herself. She'll do a much better job.
Thank you, Tamara. I know a few people in the room. I've been in DC for a while. I'm an infectious disease physician who treats people with HIV, but also have been involved in quite a few programs. I'm part of the Center for AIDS Research at GW, and also we are working on the multi-site study to look at the expansion, the feasibility of expanding testing and linking people to care. So this is a very timely topic, and it's something that obviously is of great interest. So I'm really excited about this program today. But before I introduce the speakers, I just wanted to get a sense of who's in the audience today. So if you prescribe antiretroviral therapy, can you raise your hand? A few, okay. Social workers? Okay. Nurses? All right. And nurse practitioners, so I'm including you in that group. Physician assistants? Okay, case managers? Did I miss anybody?
Yes.
Who did I miss?
Substance abuse.
Substance abuse, okay. Pharmacy, who else? Okay, but it looks like we have the predominant group is social workers. So I'm a little bit interested in what brought you today. So just shout out the reasons. What is so intriguing about this topic? Okay, except for the CMEs. I thought it was the topic that brought you, and I know it has to be the topic. One second. It has to be the topic, because I used to run the AIDS Education Training Center, and we've never had this kind of volume at most of our programs. So I know that there's something about this topic. So I've already heard somebody say that there's a controversy around this topic, or it's controversial. Any other reasons that brought you out, besides it being a controversial topic?
For me, I'm interested in the research.
Interested in the research, okay. Anything else? All right, well, our faculty today are very approachable, very down-to-earth folks, so I want to encourage you to dialogue with them while we're here, because they are both experts on this topic now. I don't have their bios, and I apologize for that, so I'm actually going to lean on both of you to expound on your bios before you start talking. But I'll introduce them together, and then when they each come up, they can tell you a little bit more about their practice and what they're doing. The first speaker is Dr. Rick Elion, and he is the Director of Clinical Research at Whitman-Walker Clinic. He's also an Associate Clinical Professor at GW. He's very well known for the research that he's been conducting in the district for a while. He's also a clinician and has lots of experience providing infectious disease care to patients at Whitman-Walker. The next speaker is Dr. Amanda Castell, who's an assistant professor in epidemiology at the GW School of Public Health. Dr. Castell has a very long public health career, starting at the Centers for Disease Control in Atlanta. And she will be talking after Dr. Elion. So let me just make some comments about what you're going to hear today and how we hope that you'll engage. Dr. Elion's going to talk about, he's going to talk about prevention, but we really wanted him to help us understand how we've arrived at the CDC's position that we can actually use antiretroviral therapy as a prevention tool. So what are the data that substantiate that? Where did it come from? And what are some of the issues surrounding that? We've also asked Dr. Elion to talk a little bit about the implementation. So, okay, so this has been approved. It's been approved by the FDA. The CDC has endorsed it. As practitioners, how are we supposed to use this information? How do we implement it? So we've asked Dr. Elion to talk about those things. Dr. Castell has some very interesting data on provider attitudes provider knowledge and attitudes about PrEP. So I think sandwiching Dr. Castell between Dr. Elion's two presentations gives us a nice way to segue into our question and answer period, because you'll have information about the science, you'll know a little bit about the challenges of the implementation, and you'll hear what providers like me and other folks think about operationalizing this. So with that, I'm going to invite Dr. Elion to come on up and give us the first presentation. And thank you for spending time with us today. I know it's a long commitment for you, but I appreciate it.
My pleasure. I mean, it's a terribly long commitment. I came from 14th and S to 13th Pennsylvania.
Not
God, that's one of the longest commitments I've ever had. So before I start, let's get things going a little bit. So Lisa said this was controversial. All right, so help me. What's controversial about this? Yep.
The disease and the stigmatization. The disease and the stigma that's attached to it.
So the stigmatization of the disease, it makes it controversial, and perhaps the stigmatization of taking a medicine to prevent the disease says that you're a person at risk for getting the disease. That's called a social stigmatization, which means that if you go to, say you have a date with somebody and you see that they're taking medicine to prevent HIV, you want to know, are you having HIV or are you preventing HIV? And if you're preventing HIV, what kind of behaviors might you be doing? Is that what you're saying? Yeah, more or less. More or less. All right, what else? Who else? Yes?
There's a fear that it will decrease condom use. That we're almost permitting people not to use condoms by promoting PrEP.
So there's a fear that by if we tell people that they can take a pill to prevent HIV, they'll stop using condoms.
And maybe not adhere to actually taking the medicine.
And also not take the medicine, so that we would unleash a increase in cases, because people would have a false sense of security, they wouldn't take the pills, they'd stop using condoms, and we'd go backwards in our prevention efforts. Okay? So this issue of increased risk behavior with this is something that we'll definitely deal with in the presentation, and we'll talk about that, but it's a very common concern. And I will not make further comments on it until I get into the slides. But it helps to understand where people are coming from. Yes?
There is also a concern when there are people living with HIV/AIDS who are not getting medications, and they are just adding to these people, those people who are not infected, to take this medication.
So the idea is that we currently have a situation in the United States where not everybody who needs HIV medications, who's HIV positive, can get them. And now, despite those shortages of providing medicines to those communities, we're talking about giving some of these medicines to people who aren't even HIV positive. Am I capturing your concern?
Yes.
Okay.
Yes, and that the focus is really not, the concern is not so much for the person taking PrEP, but for society as a whole.
Yeah, so what do you mean by that?
And there have been conversations that it reminds me of the methadone program. The methadone was designed really not with the heroin addict in mind, but with the idea of decreasing crime. Mm-hmm. And methadone is very, very destructive to the body. Mm-hmm. It's much, much worse. Methadone addiction is much more destructive on the body than heroin.
The lady up front has raised the possibility that PrEP might be a medicine that is intended. I'm not quite sure. I'm not sure I understand your point, but as I understand it, that you worry that PrEP will be like methadone. Methadone was originally prescribed as a medicine that might help people who were addicted to opiates, and I think most of us who work in the field, and I've worked in substance abuse for a long time, wouldn't say that methadone really helps that much people who are addicted to opiates. It just gets them addicted to methadone. But it does keep them from stealing as much, which was really the intent of people who wanted to keep, not really treat their substance abuse, but treat their social behaviors. So I think what you're trying to say is that we're not going to, and how would this be analogous to that?
Well, just isolating, and isolating HIV. It's like just putting them, if we, and I think that this is, it's different. I don't particularly see it as the same.
I see your point.
But it's a way of, okay, figuring out if we put them over there,
I got it. So
then society will not be burdened with HIV.
I see. So in other words, what you're saying is that there are social reasons why people become HIV positive, as evidenced by the fact that people of color are more likely to make up new incidents of cases coming into HIV. Various populations are not equal in terms of their risk of HIV, and that we would not deal with the social determinants of the disease, but just find yet another way to have a pill that would shift the reason for dealing with the societal issues into a pharmaceutical solution. Is that more your point? Great point. Great point. We're going to get into all these, but what I want to do is I want to stir up the room so that those of you who came here, because it's unprecedented that we have this many people, and I know you got to do it because it's required, and I can't even believe how good the lunch was, but because I come to these all the time. By the way, this is by far the best lunch that you've ever. So what I want to do is, when I present the data I'm going to start, I want you to feel, we have way more time than we need today. Amanda and I work together a lot, and we're going to try and join our presentations together. And I think it would actually be useful when we get into the question and answer part. We'll do them together because each of us has slightly different perspectives on this issue. But please don't hesitate to interrupt me. And if you interrupt me too much, I'll say just wait till the end. But I'd rather you interrupt so we get it at your points of view, because this idea of PrEP is a long way from happening. Currently, at our clinic, where we have 3,000 HIV positive patients, where we have probably, God knows, at least 9,000 to 10,000 HIV negative patients on top of that, we have a total of 10 patients doing this right now. So this is not an idea that's begun yet. It's already been approved by the FDA, but it's not been, the community hasn't bought into this yet. And we're going to talk about, that's what we're going to talk about today. So with that, let me get into the slides. Okay, so the first 20 slides are administrative, so I'll go through them quickly. This is for continuing education. It's sponsored by a program through Rush University and Practice Point Communication, who helps to coordinate this. That's me. There's your accreditation. Gilead gave an independent grant. Gilead is the company that makes the medicine that's used for PrEP. They had no input into these slides. They weren't allowed to comment about it. They just gave the money. That's buying your lunch, and bought the presentations being created, but they had no input over the content. There's credit by the College of Pharmacy, by Association of Nurses in AIDS Care, and CME credits. I sure hope there's credit for the social workers, or they'll all be unhappy. Dr. Kessler was the course director in Chicago, Dr. Hawkins in Santa Fe, Dr. Simon. This is the disclosure information that says that the content has been very meticulously gone over in terms of its objectivity. If you feel there's any bias or slant or commercial bias, please put that in your comment. There's me. I work with a lot of companies at the clinic doing clinical research, and so those are all the companies that I work with. You could say that I could be prejudiced because I work with Gilead, or you could say that because I work with so many companies, I'm no more prejudiced by them than anybody else. In the end, you guys will be the ones to judge if I gave you a biased presentation. I will say some things that are off-label. I'll let you know when I say them that they're off-label. This is now currently an on-label use of this medication, so we'll get into that when we start. And this is important. Lisa said, and I guess Tamara said, that this is important because of the question about they get their funding, but more importantly, we want your input. If you guys think this is a fair presentation, say so. This is a new topic. This is just starting. So they're going to be doing this across the United States for the next couple of years. So please comment, be vocal, don't be shy. the learning objectives. You can read them quicker than I can say them. There are other learning objectives. Basically what the point of this is to help talk about reasons for testing and reasons for learning about different schools of prevention. This is not intended as a talk just on pre-exposure prophylaxis. It's about what are the needs of prevention and how does PrEP fit into that, and what are the other needs of prevention besides PrEP. I don't think Amanda or I see ourselves as technologists for a pill that's going to prevent HIV. Not at all. We're people who care about the social issues that you raised and about making sure that we can find a toolbox of appropriate tools to help everybody deal with what's the appropriate way to prevent HIV for them. And so what we hope to do is to see if there's a role for PrEP in that toolbox. But if there is, it's a role, it's not the whole toolbox. There's going to be other things that are necessary. So I hope your concern about not using medicine to substitute for social problems will be addressed in the way we do our presentation. And I really appreciated your point. So let's talk about treatment and prevention gaps. When we were doing developing a protocol for prevention that we're currently doing in the district, this protocol is looking at ways to help engage people in care. One of the people on the phone line, who's a healthcare provider in the district, said, well, why do we need to worry about all this stuff about prevention? No, we're not getting new cases of HIV. This is amongst an HIV provider. Do you remember when that happened in the phone call? So they didn't know that there was an increasing incidence of HIV. Well, there is. There's an increasing incidence of about 8% of new cases a year. When you look at annual rates of death, HIV is still making up one that's just below homicide. So HIV is still extracting its toll on America. Though Magic Johnson bought the Los Angeles Dodgers, though he looks incredibly healthy and good, there are many people who aren't doing as well as Magic. 30% of adolescents, when they leave the Children's Medical Center program in 2009, died within 12 months before they got linked to an HIV program. That's teenagers. So if we were doing such a good job socially, why are kids still dying 3 years ago? I don't think we went from 30% to zero either. There's gaps in the transition and linkage between programs. When we look at AIDS prevalence, you see that AIDS prevalence is increasing, and that's partially because less people are dying. So we have more people living with HIV, but the incidence, the persistent number of new cases, runs about 60,000 cases a year. So the idea that new cases are not happening anymore, well, that's not true. And if you think about it, for a disease where we've known about the test for HIV for 17 years now, most people know about how HIV is transmitted, that we're still having 60,000 new cases a year is kind of mind-boggling. So the idea is that if all of our prevention strategies were working, we wouldn't be having 60,000 new cases a year 20 years later into the epidemic. We can't think that prevention and the ways we've been doing prevention have been totally successful. Otherwise, we wouldn't have this number. The number of undiagnosed people is somewhat related to the age. We know that not all ages think of themselves at HIV risk. In fact, most ages don't think of themselves at HIV risk. The highest group is the age of 13 to 24, and the next highest group, 25 to 34, and then the 35 to 44 group and the greater than 55 group are tied. Look at the percentages in the greater than 55 group, close to 20%. In the district, we have a very aggressive program for testing called Optout. Who doesn't know what Optout means? About a quarter of the room. So Optout testing means that when your doctor or your healthcare provider wants to get an HIV test on you, they don't ask you to sign a consent. They say, okay, we're going to get your, I actually play a physician in real life, and since I am a doctor, and I would say to a patient, we're going to check your cholesterol, we're going to check a urinalysis, I'm going to get an HIV test on you, and we're going to get a test to see if you're anemic. And if you don't say anything to me about, doc, don't do the HIV test, but do everything else, I just go ahead and I do that. We nest it within the test. We don't go through a separate consent. We did a study at our clinic to show that people who had a separate consent versus people who had no separate consent for HIV 6 months later had higher risk behaviors. Higher risk behaviors. So we don't think consent is very, very helpful anymore. We don't think it adds much. People, it's not 1987. People in 2012 know what the story is for the most part with HIV. People who don't read a lot, know what the story is with HIV. It's not a mystery disease. We know that when we think about how HIV is spread, still we're dealing with a lot of spread from MSM contact. This slide doesn't express it very well, but close to 70% of new cases are spread by MSM contact. We no longer talk about risk groups. The reason we don't talk about risk groups is there's a number of heterosexuals who have MSM contact. That has names for that kind of phenomena down low. But the point is we don't want to talk about risk groups because that leads to the social stigmatization. It's much better that we just talk about behaviors. It doesn't matter what group you're in, it matters what you do. So we're not interested in what group you're in. In terms of patients being aware of their infection, we know that once patients get aware of their infection, they're less likely to transmit HIV. It doesn't mean they won't, it means they're less likely. We know that about 25% of the folks who are unaware of their infection are responsible for over half of new infections. So what's the most important message we're going to give you about prevention today? Say it again. Say it again. And you can say it 10 times every minute. Because of all the things I'm going to tell you today, there's nothing more important than getting tested. If your grandmother's never had an HIV test and she's under 75, ask her to get tested. If she's over 75 and she's sexually active, buy her some gifts and tell her to get tested. But the point is, we want everybody to get tested. The 13-year-old who goes to the pediatrician who says he or she's never been sexually active, get them tested. Everybody get tested. How often should you get tested? Annually, unless you're a high-risk group, in which case you get tested every 6 months. In San Francisco, where a lot of the men who are having sexual contact with men are getting tested every 3 months. Because they're getting tested so often, the HIV test is a test that requires an antibody to the virus. So it requires the body to make a response, and it takes time for the body to produce that response. That period from when a person's body is exposed to the virus to when they produce an antibody is called the window period. It takes anywhere from 4 to 6 weeks. When men come in every 3 months for tests, that window period makes up a greater percentage of the time between tests. They have found that in San Francisco, in that population, 20% of the men getting their tests who find out their tests are negative are positive. Because the test isn't reflecting because it's in that window period. Everybody understand that? We're starting to look at new strategies to do testing, which we'll talk about in the PrEP stuff in a little bit. This is a slide that I tried to make the black print come up white, and I spent about 10 minutes on it last night, and I couldn't, so I'll just explain it to you. So imagine we start off with 1,000 patients in Washington who are HIV positive, and that's the bar all the way to the right. Well, and we're going to look at how many of the 1,000 do we get under control. So the first 1,000, we lose 200 to 250 right away because they don't know their HIV status. Okay, so that's the first drop. The second drop is we find these people, we get the people who get their HIV test, but we can't get them to go to the doctor. They don't have transportation, they don't have insurance, whatever. So now you're down to the third bar. The third bar gets to see the doctor, but they don't like the doctor. They don't like the place. They came to Whitman-Walker, they didn't like our waiting room, they didn't like our policy, they didn't like the fact that they had to pay $1 copay or a $5 copay or whatever the copay was. They didn't like when they went to see me, they didn't like what I was wearing, they don't come back. We think that's not a big group, but it is. It's probably 15% of people who, when they go to a healthcare facility, they don't like the way they were treated and they don't go back. Or they're uncomfortable, whatever the reason is. But before you know it, the 1,000 people are now down to the fourth group, down to below 50%. So 50% of the people who are HIV positive don't even get into care for a variety of reasons. They don't know they're HIV positive, they can't get transportation, they don't have appropriate insurance. At the clinic, 95% of the people who come through our door, 97% of district residents, we can find insurance for. So it's not really an issue of access. It's not an issue of access, it's just that people don't want to access, or they have other addiction or other psychiatric disorders that prevent them from accessing it in a consistent way. So by the time we get down to this group, we're now down to 400 patients. Of those 400 patients, we're able to control about 85% of them. So at the end of the day, 1,000 people in Washington, D.C. turn out to be a third of the population who's not going to transmit HIV, and 2/3 are still transmitting. That's a social travesty. That's a failure of a society to deliver what's appropriate care because we don't have a model that works. This same model has been used in 7 different municipal districts to validate it, and it's the same in different cities. So it's not germane, it's not special to Washington. It has to do with the difficulties of accessing care and staying in care, staying engaged in care about a disease that carries a social stigmatization and is also scary because nobody wants to die. So unless we figure out ways to help deal with this, the true ways we're really going to have prevention is never going to happen. So for you with the question in the front, tell me your name?
Karen.
Karen, because Karen's point was so well taken. This is this is the first main message I want to leave you with today. This is the problem with prevention. And how do we deal with this? This is a structural issue. This is a very complex issue to fix. And make sure in November you vote. I didn't say who to vote for. I'm not allowed to make any political comment during CME events. I just said to vote. We know that when people find out about their status, they're more likely to act responsibly. So here's patients who are aware of their own serious status. You see the reduction, the prevalence of reductions. In other words, how much people are trying to prevent HIV increases. Knowledge improves behavior. The idea that people are going to act out irrationally because they're dealing with the shock and grief and do things irresponsibly is not true. So that, first of all, sets the idea about the social factors that lead to this. And so if we're going to deal with prevention, we can't do a good job without dealing with those social factors. We have a study going on right now in the district called Test, Link, and Care. Who's involved in any sites that are involved in that study? Raise your hands. Yeah. So Test, Link, and Care is we're giving financial incentives to patients who come in and get their blood work done, financial incentives to patients who see the doctor after they get their blood work done, and financial incentives to people who take their medicine successfully and lower their viral loads. We can imagine the conversation that could occur. You mean you're giving HIV medicines for free to patients, we're giving life-saving medications to people, and then you're paying them to take them. Can you imagine what that would be in a political debate? Yes, we're probably going to hear that. And the answer would be, we found that currently diseases that deal with chronic diseases all have X amount of dollars that we use to help improve adherence. If we can improve the adherence that they get with less money, are you opposed to that? No. So that's the intent of that research. So that's about 2/3 of the way through. We'll see if it helps. The jury's not in. All right. We've come to a point that we know that the amount of HIV virus in a person is very much relevant to how likely they are to transmit HIV. This is a study showing that the higher the amount of virus in your blood, the more likely you are to transmit. The lower the amount of virus you are, the less likely you're going to transmit. And so I'm going to introduce an idea here that's going to push Karen's buttons a little bit, but not too much, I don't think, which is that originally when we talked about methadone, methadone was considered one of the first efforts to do harm reduction for substance abuse. The idea saying that we can't get people to stop using drugs because they don't listen to what we tell them. The reason why people use drugs is more complicated than healthcare can get involved with. We're not successful at that. So rather than use that drug, we're going to give them a different drug to use that's not going to be as bad for them. So that's one method of harm reduction. We can debate or not, and I would say methadone's not been a very good drug for helping people get off of heroin, but it was an initial effort to do harm reduction. What we're now going to talk about is PrEP as harm reduction. We're going to say, you can argue that condoms were a way of telling people, we're not going to tell you whether to have a lot of sex or not, but if you're going to have sex, use a condom. That's not telling people whether to have sex. It's telling them if you're going to have sex, just use the condom. The same way birth control pills were not thought of, we wanted women not to get pregnant, but we didn't tell them whether to have sex or not. So the idea with PrEP is that we're going to start to think about, can we start to re-engage people around the concept of sexuality? Sexuality is not a concept that anybody likes to talk about. Well, you like to talk about it in large groups, but not in small groups. Because doctors don't like to talk about it. Maybe social workers are better at it than other people, but I'll bet not. I'll bet you guys act like you're interested in it and good at it, but you're not really any better at it than we are. Because people get kind of squeamish about talking about real sex when they're talking about to each other, unless, of course, they're online or in a chat room and they talk all you want. But anyway, this is to show you that when people's viral loads are lower, the risk of transmitting HIV is much less. We know that over time, the success of regimens to decrease the amount of HIV in people's blood has increased for populations. We know that in the risk in heterosexual couples in Uganda, you can show a direct relationship between the height of the viral load and the risk of transmission when you don't use condoms. And that leads us to this experiment in San Francisco, which showed that when more people in the community started to use HIV medications, the average amount of virus in the community started to decline. In other words, you started to sterilize, in the HIV sense of the word, the community by having more widespread utilization of HIV medications. Anybody have a question about that? That means that when people had sex, they were less likely to transmit HIV. Now, one thing interesting during this time in San Francisco is that the number of STDs went up. So that says that people were not necessarily having less sex, but when they were having sex, either they were finding people who were the same HIV status as they were, that's called serosorting, that maybe they were having sex with those people, or when they were having unprotected sex, they were transmitting HIV. The same thing was done in British Columbia in a group of IV drug users. So the idea that you could have this benefit amongst different communities is an important thing to HIV, showing that the number of HIV diagnoses started to decline as the number of people on HIV medications started to increase. However, both these numbers in Vancouver and in San Francisco plateau. They stabilize out, and so you don't see a lot more net reductions. So just getting people onto HIV medications who are positive is not necessarily enough to totally squelch the epidemic. This brings us to this particular study. This study, HPTN-052, was considered the most important study in science in 2011. If HIV was still on people's back burners, a study that could be listed as the most important publication wouldn't be considered the most important if HIV wasn't still one of the central elements that defines society today, and I still think it is. This study took a look at giving people, it took two questions. One, how early you start people at HIV. I'm not going to deal with that part of it. But giving HIV medication to discordant, to partners in a discordant relationship. So if a man and a woman were together and one was positive and the other negative, you treat the positive and then you see what's the risk of the negative getting HIV. You tell them to use condoms, you tell them to do all the things they're supposed to do, but you know they all don't, but you see, and then you wait and see what the results are. And the results of the study were very rapidly shown, so much so that they had to discontinue the study because it was so obvious that this study worked. And so there's no question these days to understand the public health implications of treating people with HIV. It's one of the reasons why we no longer have a threshold for when to start HIV medications. Because we know that the earlier you start, the less likely you are to spread HIV. And if we're going to look at this as a disease not just for individuals, but for a community, you want to start early. Are you guys all right? Are you sleeping? Or are you just interested? Or there's no comments? I hear nothing. I'm used to people in Washington talking when I get here. All right.
You have a question back there.
Yeah, I have a question back there.
I have a comment. Well, the question more or less. If we can go back a little bit.
What's with the more or less with you? I want you to take a stand. You're asking, you make it a comment or is it a question?
It's a question.
All right, go ahead. What is it?
I'm taking a stand now. You mentioned earlier that the higher the viral load a person has, the more likely that person is to transmit the disease?
Correct.
Now, that is from a medical point of view, isn't it?
I guess you could say that. But
right.
Go ahead.
Now, how does that relate to a behavioral point of view? For example, a person with a high viral load, from my point of view, and from a point of view of good morals, is supposed to be less likely to transmit because of the guilt that person is feeling with it, don't you think? Not necessarily?
If guilt drove it, then we wouldn't have the problem.
Yeah.
Whoa. First of all, thank you for asking that question. That's a question that reflects a personal point of view, and I think it reflects an attitude that is not uncommon amongst people, and that people don't always like to talk about the moral and ethical issues of sexuality in a public setting. So I appreciate your asking the question. So that's the first thing. Thank you for asking the question, because many people think like you but don't ask that question. So thank you for being the one to do that. Now I'll answer. I think that the intention, you asked about medical, which gave me a clue to your question. I'm not describing any data that has anything to do with medicine. I'm describing things that have to do with statistics. And statistics sometimes it's related to medicine, but not always. What I'm trying to do is to use science as a tool that helps us understand how to predict things. And it's my experience, and I am also a superstitious, imaginative person who believes in other powers that aren't related to arithmetic, that I still believe arithmetic offers us the best chance to predict the future compared to my guesses. So my ability to understand people's intentions while they're having sexuality are never as good at prediction as it is if I look at their actual behaviors. And when I look at their behaviors, I can make two statements about sexuality that are fairly clear. Number one, the risk of HIV increases with the amount of virus in the person who's positive. That is an absolute truth. Number two, the various ways that sexuality can be performed, assuming it's not using a condom, carries a relative increase in risk for certain behaviors compared to other behaviors. The relative increase in certain behaviors doesn't compare to the increase with viral loads. Viral loads are a huge determinant, independent for what kind of sex you're having. So whatever your attitude is, whatever your guilt is, whatever your moral situation is, the biology of risk is related to A, how much virus there is before you have the contact, and B, what type of sexuality is being practiced. Type of sexuality, I mean technically, not emotionally. Yes?
No.
You talking to her? Talk later.
Somebody signed this off.
I know, I heard you. I'm just walking back. Yeah? Go ahead.
Could you expound a little bit on serial sorting?
Serial sorting, yeah.
Right. I have a client. I just finished a contract, and he's HIV positive. His partner's HIV positive. Of course, they're involved. And neither one of them will seek treatment because their position is they have the same kind of HIV and they're monogamous, so no harm, no foul. It doesn't make sense. Those are his terms, no harm, no foul.
Right. So, first of all, so this is a common thing I hear. And let me backtrack for a second. So serious sorting is based on the idea that if you're going to have sex with someone who's also HIV positive, you can't catch HIV. That assumes that the HIV that person A has and person B has is the same. Well, we know that's not true. Unless they caught it at the same time from the same person and they never had unprotected sex with anybody but the same person, and each time they had that unprotected sex, they had that sex in exactly the same kind of way. They would have been exposed to the same kind of biological exposure, which was a whole lot of assumptions. That's not true. Everybody who lives with HIV is living with their own unique virus. And so the ability to truly serious sort, because a virus will mutate in some people differently than in others. And so what's in Herbie is not necessarily in Harry, number one. However, because people don't think of the differences in HIV as important as the fact that HIV positive is important, if you ever go to any of the places where people use social media to find sexual partners, either newspapers or online things or Grindr or these other different places that people can find sexual contact, there's huge issues around serious sorting that men will look for when finding other men. And it's based on the belief that you're better off having HIV positive when you're going to have sex if you're already HIV positive. Medically, I can't give any justification for that, but I can just describe the phenomenon. That answer? So there is a foul. Now, is that the same foul as if a positive and a negative have sex? Probably not. Probably it's a bigger foul when a negative and positive mix. But I have patients who are having sex with somebody who's got resistance to one or two of the HIV meds, and the other person doesn't have resistance. When they have sex, they catch the transmitted resistant virus from the other partner, and now somebody who's never been on meds finds out that the first cocktail I want to give them is not going to work. So that's a foul. Okay? Yep.
When the study when the HPT-052 study was conducted, so one is positive and the other is negative.
Right.
So did they see if there is any variation when the man was positive and the woman was negative, or vice versa?
Yeah. So the question is there a sex-linked difference to the risk of HIV transmission? And the answer was no. And that's an important question. But what they did find was this issue about linked transmission. This is the slide that shows that. So what they showed is that it worked for both when the male was positive or the female was positive. There was no difference that way. This idea that HIV is easier for women to catch from a man than vice versa, because we know that it is a little bit higher risk behavior for a woman to have receptive intercourse than for a man to do insertive intercourse in terms of the risk of transmission. There is a difference, but the overall risk over a period of 1.5 years, it didn't matter if the patient was on the medication, because the medication eliminated that difference. So it definitely was a benefit of both. However, because couples don't always have sex just with people in the couple, of the new infections that occurred in that study, about 1/4 of the new infections occurred outside the couple, which is why just treating the positive person for the negative person doesn't always mean the negative person's safe, because if the negative person has sex with someone who's not their partner, all bets are off. And that's what this study shows, that linked transmissions, you could show them when the virus was linked, but unlinked, meaning it was outside the relationship, they weren't protected. Makes sense. Yep.
And that brings up my question, my next question. Now, what is the rate of infection or transmission among couples where one partner has external sex outside of the marriage and then comes back into the marriage and transmits it to his or her partner? How often is that occurring in your study? Or maybe you haven't conducted that kind of study?
All we can say, I don't think we know. That's a very difficult question to answer. What we can say is that in the studies, I'll show you the PrEP study shortly, which will, so when we do a study like this and we really try and get at what people's behaviors are, you have to assume that you can't capture that people tell you their behaviors truthfully. So all you can do is really look at what the numbers are over time. And what the numbers in this study were, there was a 96% reduction in transmissions within 1.5 years. So they might have been having some sex outside that was responsible for some of them, but the overall impact of treating the positive partner was so big, the study couldn't be completed. The PrEP studies I'll show you, you'll see the data in a second. Now, it's not a foolproof being on medication. I told you 96%. The reason is that sometimes there's still, here's data to show you that among semen, you can sometimes get HIV in semen as much as 1 in 20% of the time, 15% of the time. So taking medication doesn't eliminate the risk of transmitting HIV. It just decreases the risk. Okay? So that brings us to the question of PrEP. So PrEP is defined as pre-exposure prophylaxis. And the rationale for this really came about by looking at studies first with animals. And when tenofovir was first developed, even if you look into the patent of tenofovir back in 2003, and back in research that was done back in the 1990s, they were able to show that in an animal model, that if they had some sort of amount of the drug in Truvada, tenofovir, in the lining of the animal, either through ingestion or through a gel, that the risk of HIV was greatly reduced. that gave investigators, and not related to the company, but independent investigators originally in South Africa, the idea that they needed to develop techniques that humans could use. And the first group they wanted to look at it with was women. And the reason for women is because women don't have, for whatever reason, the same control over their choice of contraception as they would like to. And so to give women more autonomy and more power in the sexual dialogue, if you will, a gel was thought to be a good way to give women that option. The first few gels that were used were detrimental, because what the gels did is they irritated the vaginal lining, which caused inflammation, which increased the risk of HIV rather than decreased. So it took them a while to figure out exactly the best way to do that, but they did in a study called Capricio. And Capricio was a gel that they used that had a high amount of tenofovir, and it was shown that as a vaginal gel, it prevented about half of the women who used that had half as many HIV cases as women who didn't use that. When that presentation was presented at the International AIDS meeting, it got a standing ovation. And it was a standing ovation because it was really the first time ever there was something that women who, in the developing world, are one of the main groups that I think are persecuted in many ways because of sexual positives with HIV, had a tool that they could help not become HIV positive. So what are the things that we look for in a treatment that would be that? Number one, that you don't have to take it very often. It's going to stay in the blood a long time. That it's going to be tolerable and not toxic. That it's going to be cheap. That it can be stable. That it doesn't have to be taken with food. That it's safe in pregnancy. And that when you take it, you're not likely to get resistance easily. So they looked through a variety of drugs to see about this. I won't go into this since many of you are not scientists. But they found out that tenofovir and emtricitabine were two ones that were first thought to be very beneficial. And so they were the first ones studied. There's now a study on this one over here, Maraviroc, that GW is doing on Maraviroc, which is a drug that blocks entry as a prevention medicine. And the original studies I'm going to show you were all in this group, this tenofovir and emtricitabine. So this I talked about. This was the animal studies that showed placebo versus tenofovir, 100% uninfected versus 20%. So that gave rise to the idea that these drugs should be used. Then they started to look how often you had to give it. And they showed that because the drug lasted a fair amount of time in the bloodstream, you didn't have to give it to animals all the time. You could give it intermittently. So this really got to the idea as well, because we know that people aren't going to take something every day, how frequently do you have to give it that it could work? So this is the data looking at intermittent PrEP with oral tenofovir and FTC Truvada, which is the drug that was eventually improved. And what it showed here is that they could do this almost, you can still get a benefit of not quite the same, but significant by varying the dosing even down to the point that you did it every 3 to 4 days. And so it's thought that you had to dose it at least 4 to 5 times a week, and perhaps 7 to make it work. With that being in mind, the drug was approved. Let me show you some of the data that it was done from. So this is Capricio. Capricio was the study I talked about in women. This was about 500 women either given the gel or given a placebo. When given the gel, the instructions were to take a dose 12 hours before sex and a dose as soon as possible after sex. They did a very interesting study in Thailand, which I'll digress for a second, which they wanted to see if people could predict where they were going to take their medicines. It might be helpful to know which days they were more likely to have sex. So I pose the question to you all. What day do you think it is that most people are more likely to have sex? Saturday. Okay, that's not the correct answer. Dr. Fitzgerald, what day do you think?
Fitz who?
What?
Fitz who?
Fitzgerald, excuse me, Dr. Fitzgerald.
Fitzpatrick.
I keep calling you Dr. Fitzgerald, Dr. Fitzpatrick.
So I would say Friday.
Friday. Sunday. Monday. Who's ever been to New Orleans? What's New Orleans? What's New Orleans called Mondays? Blue Monday. What do you do on a Blue Monday? Take your mind off of being blue. Monday was the most common day for sexual contact. Now I know that seems like you were hoping the weekend because it's Thursday, but it's Monday. So this was the data. That was just a joke to break things up. Let's get back. But it was true. That was true. So now we have, this is the data to show you the gel, placebo versus tenofovir, and you see more cases presented with the gel. So work with the gel is ongoing. The first thing that was, first drug that was approved was a tablet, but work with the gel continues to be done. IPEX was the first study that was done on PrEP. So there were some people who wanted to see the research, so this is the research. So IPEX looked at about 5,000 gay men or transgender men. This is the first large study to make being gay part of the reason you have to get into the study. It was a huge effort. It was done in South America and South Africa and the United States. A much smaller number of men in the United States than in South Africa. And basically, it was a double-blind study where you either got the Truvada, tenofovir FTC, or got the placebo, and then people were followed for how many times there were seroconversions, what were the toxicity of the medications, what happened to your bones, what did more risk behaviors in terms of the people who thought you'd have increased risk behavior when you did that, and how often did people actually take their drugs. The study showed a benefit of the Truvada. It showed a 44% reduction overall, and about a 90% reduction in those who took all their medications. So it was deemed to be efficacious, but 44% for the whole population wasn't that as big as people thought. So let's look at why the data was only 44%. I tried to cut out some of the slides, so I'll have to speak to some of the issues. So one of the things they found with the 44% is that in this study, almost 100% of the people said they were taking their medications. What percentage of the people who said they were taking their medications actually took the medications? Not 50% is about right. It was about 50%. So in other words, people said they were taking it, but they didn't take it. And then when they measured the blood, they could find that. And what they were able to show that in those people who took it, it was 97% effective. There was virtually no cases of an exposure when people took the medicine to the proper way, which was once a day. Point one. Number two, the issue about increased risk behavior. Many people think that if you give PrEP, you'll have increased risk behavior. That once we say it's okay to have sex, more people are going to have unprotected sex. So we already know that half the people lied about telling us whether they took their drugs. So there'd be no point in asking them if they had sex, because they're not telling us the truth about the drugs. So the only thing we can do is measure how much STDs they had and measure what they said they did. In the number of STDs, there was a decrease in the number of STDs in the people who were on PrEP compared to the people who were on the placebo. So basically there was a very small increase in sexual behavior. And all of the things that they filled out didn't indicate that they had increased risk behavior. In fact, there was evidence that there was less risk behavior. That something about engaging in a study and talking to people about this issue all the time made people act a little differently. So this issue about increased risk behavior, which is a common thread that runs in our people's minds, has not been seen in the clinical trials. In the studies I'm going to show you in a second, in heterosexual populations, there's no data there that it was seen either in the heterosexual community. There's been some data, I'll get to you in a second. There's some data to suggest, based on surveys that were done at Harvard through a computer-generated survey, that there would be some amount of increased risk behavior once this comes out. In other words, people wouldn't use condoms as much. All I can tell you is the evidence, rather than the studies, don't show that. Yeah?
If that shows, if you think that part of the protective behavior is the participation in the study, has Gilead or any of the other drug companies that are talking about rolling this out, have they offered that as part of their package, that there will be, you know, case management or support groups or something that people will be tapping into in the same way as participation in the study would offer them that protective behavior motivation?
There's two issues there. One is there are materials that when they put this drug out called REMS materials that help include the need for counseling and and social contact and engagement when the medicine's given out. So they've done the things that would indicate that people need that. But let's also be clear. The data on this prior to this shows that despite those groups being available, you still have a high incidence, not maybe it would be higher, but you still have a persistent incidence of people catching HIV. So I don't think we should think that just having availability of that is going to change that. The second piece is that if we make PrEP too difficult for people to engage in, less people are likely to do it. To some degree, we're dealing with people who aren't doing things the way they were supposed to. And so if you make more hurdles for participation, you increase the likelihood they won't do it. And so that's been the tension involved in such a process. Now, we'll talk about that when Dr. Gastel comes up, because I want to talk about that issue of engagement, because we both think it's very important, but we're just trying to stick with what the data shows. The second issue about this is, would we have, we're talking about giving this medicine to people who are HIV negative. So if we do that and they're HIV positive, might they not develop resistance because we're not giving them, when we use Truvada, we use a 2-drug regimen. When we treat people with HIV, we usually use a 3-drug or 2-class regimen. So in other words, what we're using to prevent is not adequate to treat. So if we give this to somebody who's already positive, they could likely develop resistance because the amount of medicine we're giving them is not enough to suppress their virus. Everybody understand that? So there's a risk of the development of resistance. Question in the back? I didn't hear the question.
Right, but if you don't know, that's what they're saying. Like, if you are giving them the PrEP without knowing that they are actually positive, will that be creating a resistance in that person?
That's right. And so, so the data on that, and then we're looking at 1,500 patients who got that. There were 10 patients infected at study entry, 100 total. And of the patients who developed infection while on the medication, there wasn't one. So in the study, this risk of having people come in who we falsely called HIV negative, who were positive, didn't exist in the 1,500 patients that were tested. That being said, we're very concerned about this, and we're thinking of changing some of the ways we're looking at what we call HIV positive and doing a double-stage test. But that's still a question of research. The data that was generated from IPEX only used a single rapid test, ELISA test. Yes, the question in the back.
That was my question in terms of how did you determine HIV positive? What methods were you using?
A rapid test like we use in the States.
Like OraQuick?
Same kind of test. Or I don't think it was OraQuick because that's a company that makes that and they use a different company, but it's the same technology.
Oh.
It's virtually the same as that test. It's virtually the same as that test.
That could be problematic.
Pardon?
So what you're saying is that could be problematic because of how OraQuick actually.
No, I think the OraQuick test is the most common test being used, and that's the test that most people are going to be. There's different companies who make it. I wouldn't make a distinction between OraQuick or a Lear's test. The rapid ELISAs that are done is the main test that are being used, and there's no data from the studies we have to show that that was a problem.
No, I guess what I mean is with ELISA, correct me if I'm wrong, you're testing antibodies, not the antigen. So there's a window that you could be missing with an HIV positive. That's why with those types of tests, I just used OraQuick as an example. You have to use the confirmatory Western blot test.
No, let me comment on your question. I don't think you have it quite right. The first test we do is an ELISA. That's a screening test. The ELISA helps determine if a person who was exposed to HIV developed the antibody. Just as you said, there's a time period from which a person is exposed till they develop that antibody that we might miss their being HIV positive. The Western blot suffers the same issue because the Western blot has to also be an antibody that's developed. The difference between a Western blot and an ELISA is that the Western blot is a test that's more confirmatory. It's more specific, but it still suffers from the risk of taking time that a person comes in that they might be positive, but the test hasn't yet converted.
Right.
For that reason, some of the things that are being discussed is a 2-stage HIV test. Those tests are not currently available. They're not commercially available. So what we're talking about is developing of science, not current state of practice.
But what about PC? You can do antigen testing. You can catch patients.
PCR testing, which is a way of measuring the actual HIV virus, is another way to do that. The problem with doing PCRs is twofold. Number one, it's very expensive, so it wouldn't be something that most clinics could afford. It would be a real obstacle to developing this particular strategy. Number two, PCRs are very sensitive but not very specific, so that a PCR might find a value of 400 or 500, which could easily be lab contamination. And so a patient might think they're HIV positive when in fact they're not. So PCRs are not usually used as a way to diagnose HIV except in acute settings. And when you use them to diagnose HIV in acute settings, it's when the viral load is going to be over 10,000. So for PrEP, the decision by the FDA in the advisory meeting was not to recommend the use of a PCR test, because a PCR test would do a couple things. Number one, every patient who would start PrEP would all of a sudden have a $200 lab bill. It's not feasible. Number two, it's not proven that it was necessary. In the studies that were done, there was never where they did that. There's close to 5,000 patients who were treated, and the number of new infections is incredibly small. So there's no economic nor biologic rationale to justify spending $200 extra on every patient. Now, you might not agree with that, but okay, that's fine. But the data shows that if the risk is of finding people who are negative when they come in the 5,000 patients they treated, they didn't find that. Now, does that mean it's not a possibility? Of course not. It is a possibility. And because it's a possibility, there's two ways to look at that. One, they've done data to look at the risk of resistance of finding people who are HIV positive and treating them inappropriately with Truvada, how much resistance that would develop, versus the number of patients you would prevent from getting HIV positive, who would then start medication, the people who aren't prevented, who become positive, start medication and the resistance that they develop. The amount of resistance that gets developed from the patients who aren't prevented catching HIV is tenfold higher than the estimates of the resistance of the people who would be starting PrEP. So you're talking about an imperfect world with tests that are imperfect, and you're comparing the risk-benefit of different strategies. When you compare the risk-benefit of those two strategies, there's much, much less resistance if PrEP doesn't work right than in getting HIV. That being said, there are certainly, we're involved in a research study that's going to start probably in February, where we're going to test the ways we test. And we're going to have an HIV ELISA that everybody gets in the Western blot, and we're also going to have a fourth generation test to check antibodies different than a PCR, something new. And we'll also then use to see how often that's really of clinical benefit. And we'll see if that really is necessary. You're welcome. Yes?
So the current studies going on now, after the process I started with Truvada, there's something else that needs to be to test for them just in case they see.
I'll get to that in a second.
Yeah.
So the riskiest behavior that gay men do is unprotected anal intercourse. And so what they found was in this particular study that there was a significant reduction in risk if people used the medication. This slide doesn't show it very well. There was a significant reduction in the risk of anal intercourse if people believed they were getting PrEP and they took their medication. In other words, patients self-selected whether they took their meds. Those people who are having riskier behaviors seem more likely to take the medication. Now, if you think about it, doesn't that make sense? If you're participating in a behavior that you know isn't cool, and someone says there's a pill you could take to prevent HIV, you're more likely to take that than if you're doing a behavior that's not as risky. That's actually a beneficial thing. So one of the issues was that we found that when you give just Truvada alone, there was more nausea, that the medication's not benign. It's not like water, that there was a little bit more nausea, and that you see this in the first 4 weeks. And then looking at differences in IPEX, there was no increased changes in sexual behavior or high-risk sexual behaviors. Now, for the sake of time, because you guys have asked a lot of questions, I think I'm not going to present the data from the other studies that have demonstrated this in heterosexuals, because the data looks almost identical. It's not different. And so I'm going to skip through that, and I'll save it for the discussion end of things, because despite the fact that we have 3 hours, if I talk for too long, you're going to go to sleep and you won't listen to Amanda's presentation. So I'm going to keep my remarks a little briefer and give her more time to talk. One other thing, it showed that this medication has some impact on thinning of bone. So by no means should we say that this particular medication is a panacea. This medication showed about a little less than a percentage of a drop over 24 weeks, but no differences in fractures. No differences in fractures is meaningless. You wouldn't expect to have fractures after 24 or 48 weeks of this amount of bone thinning. But this amount of bone thinning is something that has to be watched. In other studies involving Truvada, usually you see about a % decline in thinning of bone in a year. Let me give you a context for understanding a percent. Percent is the same amount of bone thinning that a postmenopausal woman has when she's postmenopausal in a year. The difference is that this, in clinical studies that have looked at the use of tenofovir, that 1% plateaus after the first year and doesn't continue. So what we're seeing is a small percent. It's not nothing, it's 1%, but it doesn't appear, and studies will evaluate this, but we know in HIV positive patients who take tenofovir, that 1% doesn't get 1% worse each year. It's 1% the first year and then flat thereafter. The reason that is, for those of you who think that's weird, is that the thinning of bone is a biologically active, dynamic process. The body's depositing bone, the body's reabsorbing bone, and when the body senses there's a loss, it responds to that. People who are on prednisone, which causes bone loss, you see a bone loss initially in the first year, but you don't see it in subsequent years. The body responds to this. I'm not trying to minimize the 1%, but I'm trying to give you context to understand it. So this is Partners PrEP. This was a look at the heterosexual population. Huge incidences of reduction. 86 to 90% of those who took their medications. This was heterosexual use. So these are the guidelines for PrEP. And then I'll wrap things up and let Amanda take over. So the interim guidelines were released in January, about a year ago. I don't think the regular guidelines have been? No. Okay. So the originally PrEP was focused on the MSM population. I think that the literature we've seen since then will focus on all sexual activities. We know that it works for heterosexuals. In fact, the studies in the heterosexual community had a higher success rate than the MSM community. So one of the questions I get asked a lot is this really for gay men, or is it also for men and women? It's for all populations. And so the idea was that this would be part of a comprehensive program. It's not a pill that we give as a silver bullet. We offer condoms to people. We offer diagnosis and treatment of sexually transmitted diseases. It's meant almost as a carrot to get people into care, to get evaluated for other things, not just PrEP. It's never intended to be PrEP would be given through vending machines, like condoms can be sold. PrEP is part of a treatment program, a part of the engagement process, where people are not told that having unprotected sex is bad. We're going to rather say there's ways that we can make what you're doing safer. We encourage you to use condoms, but if you don't, this pill is going to make it less likely to transmit. That is actually a very revolutionary message. Since the 1980s, what we've told people is, well, Nancy Reagan said don't do it at all. That didn't work. We've told people to always use condoms. Well, if that were the case, why would syphilis rates be rising? Okay. So we got to face up to it that those may all be ethically sound messages, but not everybody's hearing it or doing it. So the idea is that we're going to offer something else without stigmatizing unsafe behaviors when we talk to patients. We're not going to have judgments. We're just going to try and talk about how to decrease risk. I don't talk to my children that way, but I do talk to my patients that way. So what are some of the limits? I'll skip this slide. So the first thing is to determine who's eligible, to then monitor people every 3 months. Every 1 month you see them the first month, 1 month after you give them the pills, and then you see them every 3 months thereafter. So you never give people more than 3 months pills worth at one time. Some people are only going to give 1 month's worth at one time, still being rolled out. Make sure that you're getting HIV tests and that they're appropriate for tolerating the medication. There's blood work we have to do to make sure your kidney function is fine. We get an HIV test before you start the medication, and we get an HIV test 1 month after you've been on the medication. And then sometimes people are getting HIV tests every 3 to 6 months thereafter to make sure we're not having a period where someone could be on the meds and be positive. And also to make sure that a patient is not HPV infected, because HPV treatment, Truvada, is considered what you'd use for HPV, and so you want to find out if they're HPV positive at the time you start this.
Hepatitis.
Thank you. Hepatitis B. Thank you. And then come back every 2 to 3 months, every 6 months testing for STIs, every 3 months after initiation, get your blood tested to make sure the meds aren't making you sick. So finally, getting an implementation. So who's going to do this? We don't know. We're not sure yet. Amanda and I will talk about that. But in order to do this, first of all, the first group of people who's going to have access to people who are seronegative would be the groups that all access to seronegatives. STD clinics, community clinics, prevention clinics, high incidence. But those people aren't used to seeing people over time. So now you're going to have places where people are going to offer these things, but they're going to be able to follow them. That's not what all the clinics have been able to do. We've got real training opportunities and issues about rollout and integration before we can see this ever occurring in a large-scale way, because not everyone's going to feel comfortable with it. Not everyone's going to have the resources to follow people. This isn't going to be as simple as buying condoms. This is going to be a medical treatment that we're trying to, in a sense, demedicalize, but demedicalize no more so or less so than oral contraceptives. Oral contraceptives aren't gotten in a vending machine. It's a risk-benefit equation before a woman decides to start that. And I think we need to do the same kind of thing with these medications. So to summarize up, and I'm obviously going to have more time after Amanda's done. We can't think of HIV prevention as just a pill. If we do that, we're going to lose some of the advances we've made in the past. It's never intended that pre-exposure prophylaxis is a way to be a silver bullet for HIV. But rather than that, I think there's certain people who aren't getting the message we currently have. It doesn't mean that the message isn't appropriate for some people. It's that we want to broaden what the message is. And I think part of what the challenge is going to be is figuring out, both with providers and with patients, who is this remedy right for? Who is this right for? There's currently studies to look at this given once a day, studies looking to give it 4 times a week, studies to give it before and after sex. So there's a variety of dosing strategies still being looked at. I think the jury's not in on this. The bottom line is, about 2 months ago, Hillary Clinton stood without any notes or without slides and gave a talk at the International AIDS Conference with not a word of reminders of how she could speak, and gave a lot of details and evidence about how we can start to believe and dream of an AIDS-free generation. For a city like Washington, D.C., where we have a 3% prevalence of HIV, which is the largest of any city in the United States and rival places in South Africa, for us in D.C. to talk about an AIDS-free generation for our kids is a huge leap. But I am very confident that PrEP will be part of the toolbox that will enable us to make that leap. It's not right for everybody. It's not wrong for everybody. It's going to involve individual decision-making and individual education. But the good news is, in 2012, we have more options than we did in 2011. And there's no way that's a bad thing. Why don't we hold questions from my presentation? I'm going to let Amanda do her talk. And then together, because I think you'll get more out of the two of us answering your questions together, I'll let Amanda do that. So I'll introduce Amanda. So,
Be kind.
I can only be kind. So, in the district, we've seen a real, I don't know how many of you can tell on your level, but in the last 5 years, we went from being probably one of the worst cities to have HIV to being one of the best cities. And when I go talk in places that they hear about that we have eligibility rights for 3-4-fold over the poverty level, that we help people get medication, that our ADAP doesn't run out of money, that we have a Department of Health that's very active in helping to roll out opt-out testing. People who look at me like I'm on, I've been drinking for years. Because in Mississippi, if you are poor and you're not pregnant, you can't get HIV medications. You got to be pregnant, and when you're not pregnant anymore, you don't have the medications anymore. Okay, so we have different. That's sort of the worst. But the district where the average CD4 count of people coming into care in 2008. What's your slide show? About 200, 199.
Yeah.
And in 2010, 11, we're up to 350. That is a giant like change. And Amanda has been at the health department, and Lisa as well, helping to make the health department be a much more competent, responsive place to the epidemic than it had been in years earlier. And both these women have contributed greatly to the DOH's contribution in the district, and it's made a huge difference. Amanda also works at GW as part of the public health school, and we do a lot of work together. And it's been a real benefit for me, and a real benefit, I think, for the city, to have the places that do clinical care, because Whitman-Walker still makes up about 30–40% of the HIV care in the city, to be able to work closely with the Department of Health, and also to be able to work closely with the universities that help give us a lot of technical expertise. And Amanda's helped put a smiling, normal human face on a situation that up to now has not been either competent or human. So with that in mind, give her a warm welcome.